Next session is the Telemedicine initiative in Japan. And the first one, and this session is chaired by Dr. Shuji Shimizu, and Miss Oliver from the Japan University. In this session, each paper is allotted about 15 minutes and further 5 minutes for the question and the discussion. Okay, mic is yours.
Okay, hello again, everybody, and we will start the second session. Here we have 4 speakers, 3 of them from remote area, remote site. And I myself is Dr. Shimizu in Kyushu University, and the co-chair is?
My name is Holipa. I'm from Brawijaya University, Indonesia.
Hey, thank you. So I will take care of the first 2, and she will take care of the second half. So first speaker we have today in this session is from Sapporo, northern part of Japan. They should have a lot of snow at this time of the year, I'm afraid, or it is good for them to do the ski or something like that. But anyway, I'd like to welcome the Dr. Gohira from Sapporo Higashi Tokushukai Hospital. And his presentation title is Telemedicine for Sleep Apnea Syndrome Patients Living Overseas. So Gohira Sensei, could you start, please?
Yes. Thank you for your introduction. Good morning, everyone. And today I will present on medicine for sleep apnea. Are you okay?
Yes. Well, please.
Sorry. Today I will present on telemedicine for sleep apnea syndrome patients of living overseas. And see why. First of all, let me explain sleep apnea syndrome. Obesity, small jaw, and enlarged tonsils can cause the tongue to fall down and block the airway during sleep. Aging and alcohol consumption can cause relaxation of the throat muscles and worsen the case. 936 million of men and women aged 30 to 69 worldwide are thought to have such epidemiology. Since there is a large number of patients worldwide, such is considered as a common disease. The most effective and recommended treatment for such is CPAP therapy. During sleep, patients wear silicone mask, which is fit to his face. This is to prevent tongue drop by continuously pumping positive pressure air from the device into the airway. On the other hand, it is recommended that the device should be used at least 70% of days for at least 4 hours each night to prevent cardiac disease. But past reports indicate that more than half of the patients did not have adequate treatment due to therapy non-adherence. In Japan, CPAP therapy is covered by public health insurance. Since patients need consultation at least once in every 3 months, CPAP data can be reviewed in an outpatient setting to check patients' adherence, to provide guidance, and ensure that the device is set up correctly. In some Western countries, CPAP therapy is covered by insurance as in Japan. However, in China, the country with the largest number of Japanese residents in Asia, and also in many Southeast Asian countries such as Indonesia, CPAP therapy itself is not covered by insurance. It is common for patients to bear medical treatment costs at their own expenses, undergo tests at a clinic, purchase CPAP device depending on the test result, and then continue with self-observation. No confirmation of treatment efficacy and adherence after CPAP therapy, and no follow-up on whether treatment is improving subjective symptoms and contributing to disease prevention. These challenges are present in CPAP therapy in other countries. In Asia, Japanese live in many countries, notably in China. There is also a very large number of business people assigned abroad. When patients under CPAP therapy by insurance in Japan is assigned abroad, the Japanese public health insurance can't be used. So CPAP device must be purchased and brought with them, or in some cases, they have to suspend the therapy. In 2013, Dr. Yoshimine of Inoue Hospital, Dr. Narui of Toranomon Hospital, and Dr. Ozawa of Nagasaki University took the lead in establishing a scheme funded by the Ministry of Economy, Trade and Industry. The purposes are to improve the environment and develop mass market by providing Japanese-style SaaS treatment services in China and Indonesia, and to outbound excellent Japanese medical equipment and services as a whole package by incorporating Japanese CPAP into their systems. Decided to conduct awareness raising activities and epidemiological studies on the disease locally, and we offered a trial service for SaaS screening. In Indonesia, the project was difficult to continue because we were facing problems such as a Japanese medical license could not be used locally. In Shanghai, the survey was carried out first targeted St. Michael Hospital, where the number of projects Dr. Ozawa was already treating patients, medical support service company Wellbe, which has a customer network of around 46,000 Japanese residents, and Fusan Hospital, where Japanese PSG equipment has already been introduced. For CPAP, we use a device called Jasmine, manufactured by Koike Medical of Japan, which also has branches in Shanghai and Jakarta. The device is very small, quiet, and has high performance. Besides, an attempt was also made to lower the purchase hurdle by providing treatment offering some rental plans. And Dr. Yoshimine, a co-speaker, reported that the age of the 72 patients who visited the SaaS outpatient clinic in Shanghai between 2014 and 2018 was mostly in their 40s and 50s. 36 patients who underwent PSG, 81% had moderate disease or more, and 35 had severe disease. This is indicated that SaaS has a very high prevalence among Japanese residents overseas. In parallel, seminars have been held at the Shanghai consulate. Also, Chinese doctors have been invited to Japan and Nagasaki to teach how to fit testing equipment. Education and seminars on SaaS have been held several times. Under this situation, a connection was made with Dr. Liu, director of the Pune Hospital in the Pudong New Area, Shanghai, and an outpatient SaaS clinic was established in the Pune Hospital. At the same time, ICT-based web conferencing using video conferencing system was also initiated. And this is the scheme of the actual treatment flow. The first step is a face-to-face medical interview and examination, followed by PSG test if necessary. For PSG test, we established a system of attend PSG with local staff. The PSG data is sent to Inoue Hospital via cloud, analyzed by Japanese Society of Sleep Research certified technologists, and the results are sent back. From here, let us look at the result of our efforts. The graph shows the number of patients seen in outpatient clinics each month since the clinic started in June 2014. New patients are in blue, while return patients are in red. Initially, the clinic was mainly conducted at St. Michael Hospital, but during the courses of the project, it was transferred to the Pune Hospital, where it was conducted once every 2 months. The number of patients seen per clinic was 5 to 6. Once every 2 months, a face-to-face medical interview and consultation was conducted in Shanghai. PSG test was performed and the results were explained, and CPAP was introduced using a video conferencing system with D2DP between Japan and Shanghai. We had been working on this by conducting face-to-face consultation again locally during our next trip to Shanghai, checking CPAP date, mask fitting, giving the advice, and so on. There were no legal problems as we were licensed Chinese doctors, and we conducted face-to-face consultation in accordance with Chinese law. We also gave advice to Chinese doctors regarding online medical consultation, and we were considered as medical practitioners during performing treatment. A video conferencing system by video with servers in Japan and Shanghai was used to explain PSG results and introduce CPAP to patients. Telemedicine service was provided from Japan to patients who visited Pune Hospital and their local doctors, explaining PSG results and deciding on a treatment plan. The telemedicine was conducted in this way to complement the bi-monthly clinic. However, the COVID-19 outbreak in 2019 changed the system significantly. For example, no travel to Shanghai after December 2019. This is a shame of the current system. We have developed this online medical consultation system for overseas patients, which is not covered by insurance. CPAP data from the purchased device is sent as an attachment through email. After analyzing the data, consultation, instruction, and guidance are done online, mainly via Zoom. This is the actual scene where CPAP data has been explained to patients. This is a comment from patient. He feels so nice after CPAP therapy. Lastly, I would like to discuss future prospects and issues. In Japan, on 31st July 2019, the Ministry of Health, Labor and Welfare announced that the guidance, the Japanese Medical Practitioners Act and the Medical Care Act of Japan will apply when doctors in Japan provide online medical consultation and treatment to patients overseas. In other words, if these laws and guidelines are obeyed, it is permitted to provide online medical consultation and treatment from Japan to patients living abroad. On the other hand, it is also studied that the laws and regulations of the country in which the patient is located must be obeyed. So, what about online medical consultation and treatment with overseas counterpartners in China? And telemedicine was overseas medical institutions is already permitted under the law on telemedicine services issued on 21st August 2014. If we can manage CPAP data for overseas patients in the cloud in the future, we can provide very smooth medical consultation and treatment, and also facilitate pressure change. This is considered to be very compatible with telemedicine. CPAP telemonitoring is a system in which usage and treatment data are automatically transferred from the modem built in the CPAP at home to a server in the cloud, where healthcare professionals can access the data server at any time. Many of the current models that can be remotely monitored use 4G lines, which is technically possible in 4G band countries, and many Asian countries, including China and developed countries, are already in the 4G band. Summary for my presentation. Online medical consultation and treatment is a field that will continue to develop in the future, and the same applies to the treatment of Japanese nationals living abroad in line with globalization. We would also like to further develop this field in cooperation with experts from other countries. Thank you very much.
Okay, thank you very much, Gohira Sensei. So any questions, comments from floor? Okay, oh yes, please.
Thank you very much for a nice, interesting presentation. Since you are collaborating with China, so we also collaborating some connection with China, and we had some technical issue because of the firewall. Very recently, no problem with Zoom, but very first after COVID-19 pandemic, I remember that we have some trouble to connect the Zoom in China. So do you experience this kind of connection network issues with China, or yeah, your counterpart?
In fact, after COVID-19, we this project stopping now, but counterpartner example Funan Hospital, and Dr. Liu and some hospital, we continuously connecting and email and video conference now, but no patient. We have no patients in Shanghai now. Sorry.
Okay, so if the doctor connection to the hospital, you don't have any such a problem. Okay, thank you very much.
Okay, thank you very much. So, ご平田先生、ありがとうございました。Due to the time limitation, we need to go to the next presentation. Okay, so the next presentation will be made by the Professor Nakasato, who is very famous and active in the field of epilepsy. And long time no see, Nakasato sensei, and thank you very much for your time to joining us this morning. Okay. And his presentation title this morning is Web-based and Case-based Learning of the Clinical Epileptology to Develop Comprehensive Epilepsy Centers in Indonesia. So could you start, please?
Okay, good morning, everyone, and thank you very much, Professor Shimizu. I would like to talk on this topic. The final goal is to develop epilepsy centers in Indonesia, right? Let me start the slide and then, okay, here we go. And you may know the name of epilepsy, but you don't know the facts. Epilepsy is a chronic neurological disease characterized by recurrent seizure, which is a brief disturbance of the brain function due to the electrical oversurge. And then the prevalence rate is 1%. This is a very common disease. If you have brain, you could have epileptic seizures at any time. There are lots of causes, but some are unknown. And most of you, not only doctors, but also all the people may understand that epilepsy is a disease of generalized convulsion. Let me show you some video clip. This is dramatized by actors, a very big one. Most of the people are surprised to see such a big seizure, and then you cannot work here or you cannot go to school, etc., which is a very bad stigma, right? Now the loss of consciousness, and then chronic phase of chronic sleeping, tongue bite, apnea, or the apnea, but he's not gonna die, right? It's just a seizure. Keep calm. You don't have to touch, right? It's a big seizure, but the most frequent seizure is the following, right? This is named focal impaired awareness seizure. It's not the big seizures, but this is the most popular epileptic seizures, so that you have to watch this one. Okay, here we go. The mother is talking to her son, and then now the son start the motionless staring and the consciousness disturbances, and then some automatism. Look at this left hand automatism, and he's gonna start the oral lip smacking or oral automatism. You can hear it. It usually takes 2 or 3 minutes, and then patient doesn't remember at all, so that he may drive a car, which is a big problem, right? And the diagnosis is very important. And the epilepsy may present much more smaller symptoms, like a focal aware seizures, no consciousness disturbance, just a motor convulsion or somatosensory feeling, auditory hallucination, visual hallucination, psychic symptoms, etc. Diagnosis is very important. So that for the diagnosis of epilepsy, not only EEG or MRI, but the history taking is very important. I will use usually 1 hour for patients. This is good for telemedicine. I studied the telemedicine-based epilepsy clinic 1 year after the tsunami disaster. Our area is attacked by a big tsunami and earthquake 2011. I'm not going to talk on the telemedicine clinic here today. And for the treatment, 70% can be seizure-free due to a continuous taking of medicine, right? But unfortunately, in the developing countries, the patient has no chance to see modern epilepsy care. Like in Indonesia, they say that maybe more than half of patients go to the shaman or traditional healing, not the medical hospitals. And also the patient may suffer with stigma, discrimination, etc., which is another biggest problem. So not only seizures, emotional problems, learning disturbance, psychiatric disturbance, etc., and then stigma, right? We have to tackle such problems. So that epilepsy is not only the disease of seizures, but also all the social issues. If the patient cannot be happy, let's see, maybe 1/3 of the patients should undergo admission study with the long-term video EEG monitoring. In our hospital, straight 3 days, we keep watching patients with the video and then also EEG. And then we may, wow, this is a seizure while the patient is sleeping, right? Or sometimes, wow, this is not epilepsy. This is a cardiac diseases. Wow, this is not epilepsy. This is insulinoma, hypoglycemia, So that 30% of patients are diagnosed non-epileptic diseases, right? So we are life changers. And then after admission study, we have multidisciplinary case conferences. Not only medical doctors, but also nurses, pharmacologists, psychologists, social workers, etc. So during the conference, we present patient history, the result of video EEG monitoring. We discuss about very tiny symptoms of epilepsy, also EEG findings, MRI, CT scan, PET scan, neuropsychology, and also psychosocial evaluation. After discharge, we have a EMU round. This is a case conference. Now we are running this case conference by telemedicine. And then also outpatient clinics, sometimes telemedicine. And some patients are good candidate for epilepsy surgery, resection of brain. We just studied the teleconference between the tsunami devastated area, Kisenma Hospital, but it's rapidly covered entire Japan, and then also some Asian and then North America. Our Tohoku University Tele-Epilepsy Conference is now very famous, and then Japan Epilepsy Society officially issued certification credit for the board examination. And then we say, move knowledge, not people. People means doctor or patient. We can use the telemedicine, to communicate, not only for the diagnosis, but also for the education. Education is very important to, distribute modern epilepsy care. Now Indonesia is, population is more than 2 times larger than Japan. Area is maybe 5 times. And archipelago countries, 8,000 islands with, peoples. So that telemedicine is very important. We have a friend, Dr. Wijoyo Harem. He's a neurologist in Paru, Sulawesi Island. He came to our hospital 1 year, and after he's going back home, we started tele-epilepsy lectures to students, young doctors, etc. Later, Paul attacked by tsunami, and then we did some kind of a rescue operation. We just skip it. Also, I visited some other cities in Indonesia to see what's going on in Indonesia. I realized that limited number of epilepsy centers, and then also only one epilepsy surgery center, which is a problem. And then also lots of referring delay. Many patients still see not the medical doctors, but shamans, etc., or traditional healing. And then the very, 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 very little chance of a surgical indication. And I thought it should be changed, using telemedicine, we may be able to help them somehow. This is a fun picture with my friends in Indonesian cities. And then we discussed with Nihon Koden, which is the very famous Japanese EEG companies. And then why don't you sell the EEG machine to Indonesia? And then they are very much interested. However, I told them, okay, don't sell EEG machine alone. We need to export the culture of modern epilepsy care, right? So that we collaborated with the Japan Epilepsy Society, International League Against Epilepsy, to set up the project to launch the modern epilepsy centers in Indonesia. We, for the first lecture related to the many topics of epilepsy, and then hands-on workshop for EEG reading. And this is a webinar, and then we finished 50 lectures already. Step 2 is the Teleepilepsy Conference in Japan, which is our institute, right? Tohoku University, and then I translate it into English, and then in my English translation, some here directly in English, and then also Dr. Wijoyo Harim translated into Indonesian languages, which is very exciting. More than several hundreds of participants enjoyed what's going on in our hospital. Okay, we had several times. And then third step is to develop a case conference in Indonesia, right? Indonesian side. And we, Japan Epilepsy Society members, will attend, to advise, and then also some discussion, right? Epilepsy is a disease of lots of stigma and then misunderstanding. Our goal is the education. Education is very important. So epilepsy, education, and then we need to change the life of a patient with epilepsy. Thank you very much for your attention.
Okay. Thank you very much for very interesting, impressive presentation. And actually, there are some important participants from Indonesia.
Oh, really?
So my co-chair is actually from Indonesia.
Oh, yeah, that's right. Hi.
And also some other people from Indonesia in the audience as well, and also some other countries. So I believe that there are some questions, but the time is limited, so sooner the better. So, okay, please, Dr. Ria.
Yeah, thank you for the opportunity. Hello, Prof. Naka Sato.
Yeah.
Yeah, from University of Indonesia. I'm asking about your training. Yeah, the training is about how to detect or how to manage the epilepsy. And do you manage to certify those students that you train in your training? Is there any certification based on that training? Because we are talking about skill. Yeah, how you ensure that the skill is already mastered. Thank you.
Very interesting, important questions. Actually, training of epileptology is really hard. I'm still training on the training phase, right? But for the first, we have to make many medical staff to be interested in epileptology. We have modern epilepsy care, diagnosis, treatment, surgery, and then also psychosocial workup, and also economical support, etc. So that we need to cultivate many people, so that the epilepsy lectures to the students, for example, or young doctors, after our talk, actually, I had many Facebook friend requests. one talk, 50, friends, like that. And that is important. But phase 2 is a training of neurologists or epileptologists. It takes time, not only reading a textbook or, EEG atlas, but actual case-based learning is very important, okay? Case-based learning, because there are several hundreds types of epilepsy. We have to learn one by one. And for that case-based learning, telemedicine-based system does fit, right? Okay, so that the training and also education must be continuous. Thank you very much.
So any other questions, comments? Okay, so can I ask, I myself is very much impressed, how fast and how widely your activity is, developing, after I met you and I heard your presentation last time.
Thank you.
But, I want to, if there is any issues or problem you still, have right now, or, what's your current, if any?
Yeah, for example, the, patient security issues are most important. So every time for the lectures, case conference, I ask every single participant to send me, the documents. We are not going to disclose any information for that. Well, still, I'm on the risk edge. Some may criticize Dr. Nakasato is providing individual information to the Indonesia, etc. In that times, I say just simply sayonara, but but education is very important. Okay, yeah, very good question. Thank you very much.
Okay, thank you very much. So any other questions? No? No? You? Okay, please. Dr. Tawachai. He's from Thailand.
Okay.
Tawachai from Thailand. Thank you for a very interesting presentation. I'm interested in the one who like asked how do you train the simulator, patient simulator? It's very similar with the real patient. So can you share us this experience?
Oh, you mean the seizure video clip?
Yes, in the video clip.
Yeah.
How
Actually, we paid the actors, professional actors from Tokyo, and then they came to Sendai. And then we showed the real patient's seizure attacks. And then I said, not good, not good, not good. And then take 10, I said, okay, right? It took time, but it's really fun. It's already translated into English, Taiwanese, and Indonesian languages. If you want, not Thailand language at this moment, but we have the English version, and then 9 different epileptic seizures. Thank you very much.
Okay, no more questions? Okay, so thank you very much, Nakazato Sensei, again for your
Thank you very much.
presentation. Thank you, thank you.
Okay, thank you very much. We still have 2 more interesting topic in the telemedicine initiative in Japan. The third presenter is Mr. Rafiqul Islam Maruf, with the title The Portable Health Clinic System as a Vehicle for Reaching Maternal and Child Health Care Services to Unreached Communities. Mr. Rafiqul Islam, the time is yours.
And good morning. Thank you very much. This is my pleasure to be here, and I'm very happy to see some known faces. There are many faces I knew before. I saw you in different places, and very much welcome to Fukuoka. As introduced, my name is Rafiqul Islam Maruf. I'm originally from Bangladesh, but work as a research associate professor in Kyushu University. Today, I'm going to present our work, what we are doing in Kyushu University, the portable health clinic system as a vehicle for reaching maternal and child healthcare services to the unreached communities. Actually, this research is being done in Kyushu University with under the supervision of my professor, Professor Nakashima is here. And but our target is to reach the unreached communities. So we work for the developing countries, basically Asian and African countries. And if you see the world stats, this data is little old data, but if the situation is not improved, you can find that about more than 70% people live below the BOP, the base of the pyramid. So these people are the people who are our target patient. We try to reach our healthcare service to this unreached group who are deprived of better healthcare service. And the concept is the reach the healthcare to the unreached. But in case of unreached community, the current situation, as you all know, that in the developing countries, especially the unreached group, we have insufficient healthcare facilities, and there is a lack of doctors and nurses there. And it is difficulties to access for the general people to have the get the healthcare service, even in the limited resources. So in that situation, what we can do, we take the policy that we will use advanced technology because we're working in Japan. So we will try to accommodate Japanese technology to the systems that can help us. And we try to engage local resources. As I mentioned, we don't have enough doctors and nurses in the local developing countries. But then in these countries, we have huge amount of young unemployed resources. So we try to make best use of them, how we can use them in the system. And our mission is to bring the service at the doorstep because it's difficult for the people to go to the far distance hospital. So how we can reach the services at the doorstep. So in this case, if you think about a typical clinic, what we see in a normal clinic, in a normal standard clinic, the thing that contain it is we have nurses there in the clinic, we have doctors there, we have different kind of diagnosis tools there, and you have a structure where people used to visit them. But in the rural area, as we cannot do that, so what we our policies, we will bring this typical clinic to the rural community. For that, what we need to make it portable. If we can convert the clinic as a portable clinic, then it's possible to bring it to the service to the doorstep. How we can do that? Like a nurse, in case of nurses, we will train the local human resources, local young people, male or female, and we'll give them they will have a 1-year diploma on the healthcare services so that if we can add technology with them, they can be useful in the rural community. So they will work as the rural health worker and they will bring the services to the doorstep as because they stay in the village. And instead of diagnostics tool in the clinic, we have very expensive and heavy diagnosis tools. But instead of that, we can use the portable devices because these days you will find various portable devices around the world. So, but the thing is we have to be very careful which devices we will use because there are many devices in the market and we have another study on it and we find many of them are not usable. So we have to be careful about selecting the portable devices. Thirdly, about the doctors, as we don't have doctor in the village, but we have some doctors in the urban area, cities. So we will use them and we will connect them and we'll use them as an online consultant, online doctor using the internet. And for that, we will need an online server system. So we have developed an online server system in the PSC and that connect all patient, health worker and doctors together. And altogether, this is what we call portable health clinic. So how portable health clinic works, if you think a scenario, in right-hand side, there is a patient in the village side. In the left-hand side, we have a doctor in the urban area. So what we just need the internet connectivity. If we have the connectivity, if we connect the two parties together, then we can work. And for that, for example, in the village side, if we have a patient, we have a patient in the village side and immediately when the patient is there, our health worker in the village health worker will be informed, and she will visit the patient and she take the vital information of the patient. And after taking the vital information using the portable devices, she will insert all this in the application. There is a smartphone with the device box, and there is application. When she enters all the vital information, the application has a triage protocol inside. So the system can diagnose the health status of the patient and classify the patient in 4 groups: green, yellow, orange, and red. Orange and red, we can understand these patients are severe and they need the doctor consultancy. But yellow and green patient can be served by the health worker because they don't need the medication, they need some guidance. So in case of orange and red patients, the health worker immediately knock the CT doctor, and CT doctor can see the vital information because all data is already transferred to the online server. So when it is on the online server, so doctor can monitor the current status of the patient, and immediately he can make a video call to the rural patient because we have the connectivity there. So after consulting with the patient, the doctor can prepare the prescription from his terminal. And finally, doctor send that prescription to the terminal in the patient end. So health worker can print the prescription and immediately serve to the patient instantly. Actually, the printer is a component of the PAC box. So you can see that at a village patient, being in the village, they can get investigation, they can talk to the doctor, they can get the prescription. So all service, what we can expect in a clinic, that all can be served in at home in the village. So that's why we call it a portable health clinic. So in this basic PAC box, we have this kind of 15 kind of services. This basic box was designed with a focus on non-communicable disease. Especially, we have many NCD patients in the rural area, especially hypertension and diabetic patients there. So considering them, the basic package can cover them as well. And the devices, as I mentioned, we have various study on this, and we have very selective and recommended device. Only that device we use for the PAC system. And for the triage, we have this kind of triage protocol we used, and this is an international standard. And of course, we sometimes customize it based on the national status of that particular country where we use this system. And one of the best thing of this system is all data are preserved on the cloud from the beginning. So even when we have many good hospital in our country where still we are using paper, but PAC from the very beginning, we use the online system. So all data are preserved in the online server. So anytime doctor investigate one patient, he or she can see the previous records of the patient that help them for the investigation. And in the right-hand side, you can see our prescription. It's a special formatted prescription. And here you can see in the left-hand side of the prescription, we provide all the vital information. Usually, sometimes we can see that the investigation report is separate, but we make it together for the convenience of the patients, because village patients are not that much, they don't have that much preservation facility. So we try to keep them together, although we have that all information on the server. And with the vital information, you can see some colors. And this color is very important. This color comes from the triage. And for example, if you see the color, the red one, for example, the blood pressure. Say blood pressure, in this case, the patient has a blood pressure above 200, for example. If you say 200 and your pressure is 200 and by 96, the patient doesn't understand what does it mean. But if you show your color is red, your pressure is red, then they can easily understand. And this is very important for the rural patient, for their awareness. And once they understand their situation, they take more care of their medication. Otherwise, sometimes they forget the thing. So this is very important for a PAC system. And another good thing of this triage is that you can see some data. It is the patients we supervise using this system since 2010 to 2022. Out of this 46,000 patients, you can see about 61% patient was green and yellow, and 39% was orange and red. It means that we can reduce the load of the doctor by using this triage system. If we don't have that triage system, all patients need to see the doctor. But here we can segment the patient. Those who are really need, they will see the doctor. So we can make the best use of the very resourceful doctor's time. So that is very important to reduce the cost of the service. And every patient have their unique ID, and they can, if they have the smartphone, they can access their personal data, and they can see their progress of their health status using this. Well, until now, what I was talking about the basic PHC. But when we go with the PHC service in the remote area, we find most of our patients are female patients. And we can understand there is a significant reason, because women folks are more deprived because they don't have the access that much as the men have, because men usually go outside, but women usually stay at home. And when there are maternal issues, they try to hide them because they don't have the option to see them. And in case of developing country like Bangladesh, the situation is very severe, and you can understand if you see these statistics of Bangladesh profile, I'm sure that this is more or less similar in the most of the developing country. So Bangladesh is just as an example. Here you can see that we have a huge amount of infant mortality compared to Japan, where Japan has 1.6, we have about 23, 24, something like that. So we have to work on it. And but if you see the progress of the country, the progress is very good. It's declining, but still, if you see, if we like to go from double digit to single digit, we have to wait another 20 years, 25 years. So if we like to go to the level of 1 and 2, it will take a long time. So we need to address it as soon as we can. And if you see the mortality rate of maternal mortality rate is also very huge. So we need to address these issues. That's why we made another module for PHC, and we call maternal MCH module. And the module is very simple, actually. It's we just accommodate WHO's recommendation. WHO's mentioned that we need to provide 8-stage continuum of care of the mother and the baby. That is the basic thing. And if we can implement it, we can improve a lot. But unfortunately, in the developing country like Bangladesh, in the rural area, you will find this kind of infrastructure. We call it health sub-center, but they should have this kind of continuum care. But the thing is, most of the people, they don't know about this service there, and they are not enough capable to provide this service because they don't have enough staffs there. There is no doctor, only the paramedics are working there. That is why one of the reason these centers not that much active. And we had a baseline survey. We find that only 11% of the village women, those who at least attended one antenatal and one postnatal care, just 11%. And most of the people, they don't, none we found who attended 8-stage continuum care. The reason what they mentioned main thing is they are not aware of the importance of this continuum care, because most of the people, they feel delivery time is the most important time. They don't care before and after, but that is one of the main cause of death. So this awareness is very important for them. And second thing is the distance. Sometimes the center is far distance for the woman because we don't have good quality of transportation system. So many times they feel the need to visit there, but they cannot go there. And thirdly, they don't have doctors. So they feel, even I go there, I will not see any doctor. So why should I go there? What's the benefit? So we developed the PHC MCS module. The basic module, we have this kind of instruments that some of them are useful for the MCS care. But for the MCS care, we need some additional equipment like portable ultrasound, portable Doppler machine, and this kind of thing are added. If we simply add to our system, it will work as a MCS module of PHC. And in addition, we need to introduce a new triage protocol for ANC, PNC, and infant. And what we need to provide the service at the doorstep, because PHC, the model is to provide the service at the doorstep of the patients. So that is done by this system. And for this, we have this kind of triage protocol for ANC, PNC, and infant mortality. We have developed this protocol, and I have a small video. There's no sound.
When you live in a developed country or have access to all kinds of medical services, the sound of a newborn crying creates a festive mood. But when you live in a remote area of a developing country, bringing a new life brings in a whole lot of questions. How would the 9 months of pregnancy be? Will the delivery be smooth? Would the mother and child even survive? Like most other villages in Bangladesh, earlier there was no modern healthcare facility in Momtaj's Chaigaon. After the death of the first child in the womb, the treatment of evil spirits through amulets started. However, she was actually needed to be seen by a doctor. Momtaj is lucky. During her second pregnancy, the Kyushu University of Japan and Grameen Communications of Bangladesh jointly initiated a specialized program in their village called Maternal and Child Health MCH Care, which is a part of their portable health clinic project. The annual general health checkup program of the Maternal and Child Health Project for all potential women between the ages of 15 and 49 is taking place today in Chaigaon. 500 women are about to be examined today. This general health examination consists of 15 important tests including BMI, body temperature, blood pressure, oxygenation of blood, blood glucose, hemoglobin, cholesterol, uric acid, and urine protein. While the PHC model is widely admired around the world today, in the MCH project contains several additional devices, including an easy-to-carry Doppler machine, a small ultrasonogram device, and a special instrument for measuring infants' weight and height. With the help of these, an experienced health worker can understand the physical condition of the mother and her baby. Though these health workers are at the very bottom of the project pyramid, their first task is to sort out the initial verification, primary data collection, physical checkup, and insert all these data to the online server properly. Then they connect the patient directly to a remote specialist doctor of this project through a video call. If the path shown by the Maternal and Child Health Project of the Portable Health Clinic program is followed, then the day is not far when the atmosphere of this country will not be heavy for the death of another newborn.
So thank you. And this is my final comment that you can see that this is a very cost-effective and smart technology for the unreached community. And as we can provide home delivery service, it can maximize the participation in healthcare. And this is a simple system, so this can easily replicated to any part of the world. So this is all from my side. Thank you very much for your attention.
Thank you very much, Mr. Ma'ruf, for the interesting topic. Actually, in Indonesia, we have in my district, we have some kind similar technology. We call it Smart Health Program. Maybe any comment from the audience? So I have you do have question? So please.
Thank you, Rafiq. Very impressive program. It reminded one of the projects that we conducted at the Center for Online Health at the University of Queensland with the indigenous communities, where child hearing problems are really a severe problem. A lot of the indigenous Aboriginal children get deaf. Deafness is very high because of the negligence in terms of the ear diseases, and mobile clinic created by this research project certainly helped. So I can see there's some similarities and the value of this project. Going forward and scaling up this program, how do you sort of visualize the cost aspect? Certainly it's a low cost project intervention, but at the same time, there are some costs involved training the local health worker and maybe supporting them by providing salaries and so on and so forth. How this can be done in a sustainable way?
Thank you very much. Thank you very much. And money is always very important. Well, actually, as I mentioned, we are utilizing this system in different countries, and actually, different countries they have different policy. Like in Malaysia, we are working with a Malaysian university, and they have some program with the government. So, government is funding for their outreach program. Just what they do, they use this technology with them. So it makes their job very easy. But in some countries where we don't have the government support, we have another model. We called it micro health entrepreneurship model. In that case, what we do, like in Bangladesh, we tried this model there. We hired the female health worker from the remote area, rural area, who is interested to work in their community. So we train them, we provide them the whole system, technology system, and we provide the doctor call center support to them. But they need to invest. They need to invest about 1,500 US dollar. That is their initial investment. That includes everything, including device training. And in addition, when they go for the service, they can charge the patient by themselves, because we have a standard, we set a standard for this service, because our target is to minimize the cost. So based on that experience, we try to give a low price for this cost, and our health workers, I mean the entrepreneur, they charge the patient that amount of charge. But as we use our doctors, they need to pay a share of that charge to cover the cost of the doctors. So that is our entrepreneurship model that can be worked in some country where we don't have the support from other areas. But you know, in every country, there are some social angels, those who are interested to work. If they supervise one health worker in that area, that could support a lot, at least at the initial level.
Thank you, very smart. Yeah.
Thank you very much.
Okay, thank you very much. Actually, there is so many something should be discussed, but the time is over. So we can continue to the next presenter, Mr. A.G. Oki Sensei, with the topic telesurgery in Japan from yesterday to tomorrow. The time is yours.
Thank you very much. Thank you for giving me this opportunity. I'm Eiji. First of all, I want to say sorry. I can't be there today. I will have important presentation in Tokyo today, so I can't be there. Okay. Can you see my slide? Okay.
Yes, please continue.
Okay, I want to start my presentation. I want to talk about the telesurgery, the situation of telesurgery, the developing the situation of telesurgery in Japan. This is my COS, right? As you know, telesurgery has a long history, over 20 years. Dr. Maresco has studied telesurgery, development telesurgery using Zeus system in 2001. I don't know exact pronunciation of Zeus and Zeus. This is the company name at the time, but now the Zeus company of Zeus is bought by the Intuitive. So this is difficult situation. This company is really interested in telesurgery, but Intuitive do not interested in telesurgery. That's why the development of USA is completely stopped. I know about that. But at that time, they used private line connection, and the transmission rate is only 80 milliseconds. They used French Telecom designated line. And total day was, I think, they reported 200 milliseconds. That is actually good results at that time, I think. But I'm not sure the real reason why they stopped the development of telesurgery, but they completely stopped the development of telesurgery. You can see, you can get the video from the internet. But we have, in Japan, we have studied research for telesurgery since 2002, 1 year after Maresco experiment. I listed some telesurgery experiment developed performed in Japan. First, we tried between Tokyo and Shizuoka and Fukuoka, between Fukuoka and Seoul and Fukuoka and Bangkok. This is over 3,000 kilometers. And at that time, we tried to use many type of network because we at that time we don't know that what is the best transmission commercial line, and but at that time usually we use the designated line. We cannot use a commercial line at that time, but the best bandwidth is only 10 megabps. The best latency rate is over 200. The over 200 latency is not enough for telesurgery. Actually, I will explain about that later. This is the video at the time we tried the laparoscopic cholecystectomy on experimental animal. Yeah, actually, we tried to operate experimental animal on telesurgery. Yeah, and I think we could do that. But the development of telesurgery stopped, and I think 2008 or something, 15 years ago. What was the barrier of telesurgery at that time? We had main three reasons. One important reason is robotic surgery was not widely used at that time. It is not. We didn't get the regulatory approval at that time, and the cost of broadband, high cost of broadband, is another reason. And important other reason is there was no demand for telesurgery. That is, I think this is most important reason. But things are changing recently. Robotic surgery is now covered by insurance, especially in Japan, and in many countries, robotic surgery is used in usual medical care recently. And communication costs are getting lower every year. And 5G, 5 generation can be used on commercial lines. This is also important. And demand for education on robotic surgery is increasing. This is a very important point. This is the number of robotic surgery developing in Japan. I think robotic assisted surgery is developing rapidly all over the world. That means increasing the burden on both learn and teach. Now, in Japan, more than 500 Da Vinci surgical systems are already in operation, and robotic surgery has become standard medical care. That means more robots. More robots mean more need for education and chance for telesurgical assistance, I think. So I think we need a guideline or rules in Japan. So we started to prepare the Japanese guideline since 2019 and Japanese Surgical Society. These are part of the clinical question we made when we studied to make guidelines of telesurgery. Today, I want to explain about part of these. First of all, I want to explain about how much delay of image can the surgeon tolerate. To solve this problem, we prepared the system which has artificial delay between the operator and robot. The delay was variable from 0 to 300 milliseconds. we want to confirm the relationship between the communication delay and surgical procedure. I want to show you one of the result really briefly. We found that the limit of communication delay that can be tolerated the surgeon is about 100 millisecond, like this. And we found the beginner has a big, impact on communication delay. Expert didn't have big impact. Didn't have big impact on communication delay, but I think 100 millisecond is the limit of the communication delay or usual surgeon. We actually tried a lot of tasks on this experiment, but every task, I think the 100 millisecond is the limit of the communication delay, I think. And the next, we try to, try to be clear how much bandwidth is necessary to transmit image and procedure robot signal. And I want to know the actual communication delay in commercial lines. Commercial line is very important. We cannot use a designated line in usual use of telesurgery. So I want to know the actual communication delay in commercial line. And redundancy is very important or usual use of telesurgery. So we developed a mechanism to maintain the redundancy. I want to explain that briefly. And we want to confirm the bandwidth limitation. Okay, the bandwidth limitation and communication delay on new Japanese robot. This robot is called Hinotori. We set the two Hinotori robot in Hokkaido University and Kyushu University. These are most remote distance assumed for domestic communication. And we put two measurement computers to confirm the bandwidth communication delay and packet loss during the telesurgical procedure. This is one of the result, bandwidth limitation and communication delay. We reduce the bandwidth and in step by step from 1 gigabps to 100 megabps gradually. And in this Hinotori robot, bandwidth need more than 150 megabps. If we reduce bandwidth less than 150, we see the packet loss like this and block noise like this. However, the delay, communication delay was very stable, around 30 milliseconds from Hokkaido to Kyushu, 1,500 kilometers. So we developed the mechanism for maintaining redundancy, consistency. It's just simple. We just prepare two lines of communication. We always use two communication lines. One is best effort or type or commercial line and guaranteed type communication line that we checked and redundancy. In case we lose one line, then the other line takes over without anybody noticing it. So this means I think two line is necessary for redundancy. I think the for usual use of telesurgery, I think two lines is necessary to maintain the redundancy. And finally, we checked double cockpit system. I think no one has been trying to use double cockpit system for telesurgery. So we tried the double cockpit system. This is test of switch of surgeon using two cockpit system, where we set two cockpit in Kyushu University and Bep University. We do the switching. We did the switching surgery. As you can see, young surgeon doing urosystectomy under the assistance of expert gastroenterologist like this. Yeah, I want to explain in detail. We call this type of surgery as swapping surgery. Now, many young surgeon is doing surgery, but operating field is not good. So the surgeon is changing, swapping to mentor. Now is changing mentor, 150 kilometer apart, and he is showing to Mendy how to make operating field like this, explaining and explaining. They are seeing, looking same image in different monitor, their own monitor, and mentor showing how to do the operation briefly, like this. And again, the operator switched to Mendy. Right now, young surgeon restored the surgery. This is the real, I think this is a real telesurgery. This is telesurgical assistance. Finally, we made the guideline under the Japanese Surgical Society. Unfortunately, this is Japanese, so we will publish next year in English version of the guideline of telesurgery. But in this guideline, we divided telesurgery into three categories. One is telementoring, one is telesurgical support, and one is full telesurgery. We focus on telesurgical support, assistant for surgery from distant place. But we can, of course, do the full telesurgery, complete surgery from distant place. Theoretically, we have already tried to do full telesurgery in cadaver, using cadaver. This is the full telesurgery, this is the gastrectomy. Yeah, theoretically we can do, but right now we don't do full telesurgery because the rule is really necessary. And we also can do the telementoring. Telementoring is really important in future. This is just telementoring on laparoscopic surgery and not using a robot. Telesurgery is very simple method. Now, recently, many Japanese company making the system or telementoring system, something like this. That drawing the line on the operation view. This is very simple and good method for simple telesurgery. Okay, this is my last slide. In Japan, telesurgery is moving toward realization for purpose of medical education, not only the patient convenience. Thank you for your attention.
Thank you very much for your impressive presentation. Is there any question from audience here and also in the online audience? Yeah, please. Yes, because there is someone online.
Thank you, Professor. Very interesting presentation. Cutting edge technology, what exactly Japan has been doing in many technology areas. My question is about, you mentioned in your presentation the demand for telesurgery is increasing. So by saying that, you meant that the demand is coming from the patient or the industry, or what do you mean by that? Where the demand is coming from?
I think demand is a reasonable demand of telesurgery is especially in doctor to doctor. You know, the now over 500 robot is in operation in Japan, but I think the teaching system is not established in telesurgical teaching system is not established. I think we should have a telesurgical education system in near future. I think that is the demand of telesurgery. Of course, the patient need telesurgery sometimes, but I think it's more important for education, I think.
Thank you. Is there any question? Yeah.
Professor, good morning and congratulations. A very nice presentation. I'm Dr. Domino from Philippines. You did show us that this is where the direction of telesurgery, especially using robotic system, is going, and I believe this will have an advantage, especially in remote areas. Now, my question is: there are a lot of platforms in robotic platforms that are coming out. There are one platforms, multi-platforms. Will this affect the type of brand or the type of platform if you're going to plan to use it for telesurgery, for remote telesurgery? There are different brands now, they're coming up. So do you think this will be affected?
I cannot understand your question exactly. That you mean that this which type of surgery?
Yeah. I'm talking about robotic platforms. You mentioned you use Da Vinci.
Yes.
You use Senhance.
Uh-huh.
So these are different platforms.
Yes.
But there are a lot of platforms already coming.
Of course. Yeah, that's a good point. I think the robotic platform, if robotic platform is different, totally is a system is different. We are now focusing on the Japanese robot Hinotori. I think especially bandwidth, the necessity of bandwidth in each robot is totally different. One Japanese robot is at least we need at least 150 megabps, but my other robot only need 40 megabps bandwidth, and I think the delay is also a little bit different. It's the different encoding system. So I think codec system. So I think we should confirm in each robot. It's necessary.
Okay, this is the last question for this session.
I'm Dr. Bitun from Thailand. Do you think to use the remote control surgery by robot is cost effective enough? Because even the Lindbergh operation over 20 years ago, in real life, we never used the way to do remote surgery at all, anyway, any place in the world, because I think one thing is the cost effective, not the technical in lag time or anything. Even especially for the robot, you have to pay more money. And if you want to buy $1 million, to invest $1 million US at least in a remote hospital, that's gonna be very high cost compared to, because I think the first intention to use robot probably for the astronaut to do the surgery in the moon or to do surgery in the war situation, because the doctor or surgeon do not want to go to the war zone. That's I think that's a real purpose to invent a robot. So do you think this
Yes.
can be cost effective enough to use the robot to support the hospital in rural areas? Right.
Yeah, that question is really important. Cost effectiveness is really important. It's recent. I think at present, the communication, the telecommunication of telesurgery is really high cost. As you know, the first telesurgery costs, I think, $1 million, one surgery. I think I know that. So the recently one surgery, I think it's just 10,000 or something whole telecommunication, but I think getting lower and lower, I think so. And I think it's payable in future. But and your opinion is really, I think, really important. We are struggling about the cost effectiveness and issues and right now. Yeah, thank you very much for the question.
Okay, we still have one question from online from which one? Oh. Is there any question from online? Yeah. Min Sang, Min Finaren. Okay, please.
Yeah. You hear me?
Yes. Yes. Please ask your question.
It's a very nice presentation. And I am sorry I follow your presentation from the beginning, but I hear only your voice and I didn't see the slide. So I wonder which type of network you usually use for this kind of live demonstration. Since because I most your activity I think you did it in Japan and even in 2022. I remember you mentioned the bandwidth is about 100 or 200, and I think in Japan you have higher bandwidth for this. That's my question. I want to ask about your network.
Network. Yes, network is very important. That is the most important issue to decide which network we should use. First of all, bandwidth is most important. The bandwidth bandwidth is different in each robot, and in this Hinotori, I think at least 150 megabps is necessary. So we should decide the bandwidth in each robot firstly. At least we need 150 megabps in this Hinotori robot. I think the Da Vinci is also need more bandwidth in communication.
Yes. So you for your activity you usually have the enough bandwidth, or you need to ask the network engineer for a private network.
Yeah, we don't use a private network. We use the IPVPN, virtual private, only virtual private network in commercial line.
Okay. So I because your most concern is about delay. So
yes.
I think I think we may decrease the delay if we have more bandwidth, because I don't know exactly your system. So I think if I don't know if you have more bandwidth, you can decrease the lower the delay.
Yeah, delay is not so, I think we don't care about the delay, communication delay if we have, if we prepare the enough bandwidth for communication.
Okay, so you mean the around 150 is enough?
Yeah, in this robot, only in this robot. Okay.
Thank you very much.
Okay, thank you very much, Finaren, for your question. So this is the end of our session in the telemedicine initiative in Japan. My conclusion is telemedicine is needed in the future, either it's for health system improvement and also for education improvement. Thank you very much for your participation, and thank you very much for your all the speaker. That's all. Good afternoon.